Welcome to Healthy Minds. I'm Dr. Jeff Borenstein.
Everyone is touched by psychiatric conditions, either themselves or a loved one. Do not suffer in silence. With help, there is hope.
Today on Healthy Minds.
So let's bear in mind anxiety is normal. We all have it, and all of us feel butterflies in the stomach when we're starting something new or taking on some kind of task. So parents should look, though, for when the anxiety doesn't go away with trying to get the child more and more into situations. Anxiety is the silent disorder. These kids don't disrupt the class.
So they're quiet, and they may even be, the parents may think everything's okay, they're quiet, no problems, but really, deep down, they're suffering.
They're suffering, that's right. And it's about 2 to 7 years before an anxiety disorder is noticed.
That's today on Healthy Minds. Healthy Minds is brought to you in part by the American Psychiatric Association Foundation, the Graham Beck Foundation, and the New York State Office of Mental Health. Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. Today we continue our conversation with leading experts, Dr. Anne Marie Albano and Dr. Francis Lee, about anxiety in children, adolescents, and young adults. I want to ask you a little bit about the types of symptoms that parents should be looking for and do it sort of at different age groups. What should parents be concerned about if they see this in the child?
Early on, what you see is a child, essentially all the things that would be typical, wanting to sleep with the parents, clinging to them, not looking at and talking to people that the parents are introducing them to. They have difficulty settling into school. So that, and all children go through phases like that, but the thing about it is with anxiety disorders, they don't get used to it and get over it. So let's bear in mind anxiety is normal. We all have it, and all of us feel butterflies in the stomach when we're starting something new or taking on some kind of task. We know anxiety is a necessary emotion that keeps us safe and keeps us on our toes. We'll study for tests because we're too worried about failing. So parents should look, though, for when the anxiety doesn't go away with trying to get the child more and more into situations. With young children, they're sleeping with parents, as I say. As you get into elementary school, then children who are coming home crying or don't want to go to school because they're too anxious, too afraid. I might get yelled at, I might make a mistake, the kids don't like me. If you're hearing things like that, as they move along, they drop out of events. They don't want to do Little League anymore. They don't want to be in clubs as you're heading towards middle school. Anxiety it's more common in adolescence just normatively. They're starting to think and understand long-term consequences. They understand what people think of them, what they look like. So anxiety builds. But if you see your teenager not wanting to anymore, go to parties, or do things after school. If they're in their room all weekend, they're not hanging out with friends, they're not texting others, why not? You have to ask. Anxiety is the silent disorder. These kids don't disrupt the class.
So they're quiet, and they may even be, the parents may think everything's okay, they're quiet, no problems, but really, deep down, they're suffering.
They're suffering, that's right. And it's about 2 to 7 years before an anxiety disorder is noticed that the child is brought to a clinician. 2 to 7 years of anxiety disorder, right? So they do suffer in silence. And parents, as kids are hitting adolescence, are thinking, oh, thank goodness my child is not out there, breaking curfew, taking the car. But you have to question why not. Are they not doing some of the things that are typical? And then the other thing I tell parents to think about is if a teacher says, oh, yes, Mary, I don't even, know that she's in my classroom. She's so quiet. Ooh, that's not good.
Right, that was not necessarily good news.
That's not good news, right. So we ask parents questions. Do you order for your son or daughter in the restaurant and they're 10, 13, 15, things like that. As you head towards college, then you find that the youth are not getting excited about it. They're not asking questions about college. They don't want to go on interviews. They're not interested in what the school is doing to help prepare them. And they even may start crying and melting down about this. So parents have to look for that. They're not getting into dating and talking about romantic relationships. They seem to lose friends, or they keep one or two friends who actually are more like safety persons. They're comfortable with those friends, but if those friends want to do something with a larger group, the youth with anxiety, well, no, they'll make excuses. So these are the things we have to look at there.
What I was always struck by when we've discussed this, that there's also this where it gets to a point where they actually will refuse to go to school.
School refusal behavior is a serious side effect of the anxiety disorders. It's not a disorder in and of itself. It is a behavioral manifestation of the child's too overwhelmed. And there's a number of ways anxiety does this, plus depression adds on.
So what do you do? Your child doesn't want to go to school. What do you do?
Well, we have cognitive behavioral treatments that specifically are addressing that. And I should add, depending upon the severity of the youth's illness, the preference that the parents and the youth have in terms of treatment, and also availability of treatments, medication is very important here. So I was one of the principal investigators on the largest study that the National Institutes of Mental Health had funded, the Child Adolescent Anxiety Multimodal Study, where we randomized 488 youth to cognitive behavior therapy, medication, the combination, and pill placebo. And we know that for 80% of kids who got the combination treatment got well and responded. And then the CBT alone and the medication alone, they were equally better and more superior to placebo. So we know we have 3 ways to treat.
And some people need a combination.
And some people need a combination, so.
What types of medicines were you studying, and what do you recommend as things for parents to be aware of going into their doctor's office?
We studied an SSRI. But I will let the psychiatrists talk about recommendations for medication.
So for your study, they used a serotonin reuptake inhibitor, which is in the same class as Prozac, but it's called both sertraline and Celexa. And in many ways, these are probably one of the safest medications that can be given. Literally billions of people have taken this. And I think that what I think should be emphasized is that just as with a course of CBT, it is not as if you need to be on a SSRI for the rest of your life. But if you're in a situation that, just as we were discussing, if your child or adolescent is refusing to go to school and they've been going to some type of psychotherapy modality that has been helping but has not yet, they've slipped into this pattern, what I'm struck by is that with the results from this study that came out in the New England Journal of Medicine, that 80% of the people given that combination, their anxiety symptoms reduce significantly. So this is so then in addition to seeing a CBT therapist, you would also see a psychiatrist that would monitor giving the medication to them in combination with the therapy. And during that, and at many points, once the anxiety symptoms are relieved, then the medication can be removed. It is still an open question of when that actually, at what point it is. But if your child or adolescent is not going to school, then all aspects of what is known in evidence-based medicine should be used at that point.
This is very important, that people with significant anxiety had a very high response rate with this combination therapy. It makes a big difference in people's lives. I want to ask about school refusal, because that's such a challenging problem when it occurs. And what can a parent do?
School refusal is a major problem because the youth, about 5 to 7%, up to 12% of youth refuse school through the course of, up through high school. And once they stop going, it is so difficult to turn that around. So we have to nip that very quickly when a child starts. And it is a family-based treatment approach that is needed, plus the school has to be involved. Moving your child to another school, not the way to do it. Homeschooling, please don't. Not for that reason of avoiding anxiety, because they never get back in. And so what a parent has to do is work very quickly and with an open mind, and the schools have to be open-minded. Don't point the fingers. Bad schooling, bad parenting, that's not what it is. It's anxiety. or depression, or the combination. So they have to get help. Now, the interesting thing is we talk about school refusal behavior in school-age youth through age 17, but we also have college or life refusal on the young adults who, once they get that diploma, and they turn 18, there's no one saying you must attend school. And so this is where parents are really strapped, because what do they do when the young adult is just refusing to engage in the world? And that, again, is why throughout the course of the child's development into adulthood, we need the family system involved in treatment, because therapists can help the parents to develop ways of working with their child or their young adult who's refusing, and then also get the family together to give that child or young adult skills to manage anxiety and take things on.
When speaking about a young adult, college age or post-college, sometimes it's hard to get that young adult to get treatment. The parents want to encourage it, but the person doesn't want it. What do you tell families? How do you get that young adult into care?
That's the big question that haunts parents, and parents think there's nothing I can do here. So we actually have a program for parents, even if the young adult doesn't come in. And I work with parents in groups. We get 5 parents or couples, whatever combination together. And it's about, first of all, understanding anxiety and depression with your young adult and what has brought them to the place where they are. Then around how to approach them, how to talk to them, how to set up the house in such a way that this young adult will have responsibilities and have to be a part of the house, what to make available, what not, in terms of giving them things, to help motivate them and work on the youth's motivation to change. So it's very important that we work with the parents to empower them. And then we do lots of role plays and work with them on how to talk to their young adult to get them to come in. And we try to make agreements with the young adult for a period of sessions, 4 sessions with us, before they decide that this isn't for them. So these are the different ways that we try to engage the youth through the parents, and also try to empower the parents to take control back of their home and to help their young adult in a reasonable way.
And the bigger picture of one of the reasons why Anne-Marie and I work together on the Youth Anxiety Center is, you can imagine that this is, if the young adult does not actually get launched and go to college, then their life doesn't get started. And this again is possibly the 3rd critical period. If you do not leave the house and start your own life, the options you have later on in life diminish significantly, and that your world actually becomes much smaller. And I think this is sort of the organizing principle of why we become so focused on this, not only adolescence, but this late adolescence, young adulthood period, because it is also a period that has not been studied as much, and this concern has not been as prominently brought up in terms of various interventions for this period of time.
One of the issues for the teenagers, young adults who may have anxiety is what's sometimes referred to as self-medicating, abusing drugs, alcohol to help them relieve the anxiety. And I want to ask you a little bit about that.
Let's understand that anxiety starts by age 4 or 5. And there's data from the National Comorbidity Survey of Adolescents, Kathleen Merrick-Kangus's work at the NIMH, that shows anxiety is the disorder of first onset, and it steadily increases in prevalence. It's the highest prevalence all the way through. By the time these youth struggling with anxiety hit 13, 14 years of age, they start developing depression. This is a secondary disorder, because anxiety is a gateway to that. I mean, the longer you struggle with it, the more depressed you get. And this is happening during the phase when your brain is changing. Depression and anxiety, either one or the two combined, by 16, 17 are leading to substance abuse. So again, anxiety is this gateway. And youth are finding ways to self-medicate the anxiety. I say, when I talk to parents or I give talks to groups, you're invited to the office barbecue or cocktail party. The first thing you do when you walk in is you go get a drink. And then you go out and mix and mingle. Well, kids are actually learning that with substances that calms them down. Not just alcohol, but also marijuana and also nicotine. They're finding ways of calming themselves so that they could get into situations, but then of course, it backfires on them, as we know. So we have to be very mindful of the fact that our young adults especially are doing things to self-medicate, and it's not just alcohol or marijuana, but it's also self-medicating with benzodiazepines and things that they buy from one another or find because they're in such pain.
I think it's very important, and the point of that the early anxiety then may lead to depression, may lead to substance abuse, really gets back to the importance of right away treating that early anxiety, nipping it in the bud, so to speak, and getting that early intervention.
Exactly. So that they don't feel that they need to self-medicate at some other point in their life, which then opens up another sort of can of worms of how to actually deal with the substance, in which there are not as effective treatments in that realm versus the extremely effective treatments we have for anxiety and depression. You are at a launching point where you can treat this. And again, it gets to the point that if you get treatment at the right time, you will also have probably a better response rate, because it's not just that you get, it's almost like having a cold for 7 years. The cold begins with certain symptoms at a certain point, but if you've not treated it for...
You're going to get pneumonia eventually.
Exactly.
And
each lobe of your lung gets infected, so that by the time you actually get treatment, it will take much longer. So why not treat sooner than later, I think is sort of the ideas that we have right now, that and it will be more effective, and it will also, you're also intervening at a point where the brain might be more plastic. It will actually last longer in many ways.
so an important message for young families is that as parents, and maybe as grandparents who are giving some assistance to their adult children, if they see any of these early warning signs in the young child, that they should take some steps to evaluate it and see what treatment. And the treatment may just be some guidance to the parents as to what they can do to build resilience, how they can respond to anxiety-provoking situations for the child by supporting them, but encouraging them to go out there and do that anxiety-provoking activity.
That you actually have to train the parents to allow them to expose themselves to anxiety, to gain resilience in many ways. You're essentially, the parents are the facilitators of that in many ways.
Well, if I could say, we have taken an evidence-based treatment for children that's been around for a long time, parent-child interaction therapy, that was developed for youth with oppositional behaviors, and this is for 2, 3, 4, 5, 6 years of age. And my colleagues and I adapted it. We call it CALM, Coaching Approach Behavior and Leading Through Modeling. It is a family-based, parent-based approach for young children with anxiety disorders. And other colleagues around the country are also studying different kinds of early childhood interventions that have to be worked through the parents. But they're short-term, they are effective, and it can make a world of difference. The idea is perhaps we are then either decreasing the amount of anxiety the child experiences over time, and/or we hope preventing the onset of secondary disorders over the longer term. So there are really good programs for parents out there.
I think it's such an important point about the prevention. We as a field often are responsive once an illness begins, but what steps could be taken to minimize the risk of it occurring? And helping to train parents, we encourage parents obviously to feed their children properly and bathe them and read to them and other activities like that, but teaching parents how they can better help their child develop resiliency is an important thing for parents to know.
What I try to do with parents is ask them, because look, these treatments take time. You've got to get to the therapist, you have to work an hour at least a week with the therapist and so on, and you have to do things at home. This is the thing with cognitive behavior therapy, there's homework. But what I try to help parents to work with is how to prioritize this, because doing this now, and now could be when the child's 5, 15, or 25, doing it now is an investment so that there's not a longer term of difficulties and struggles that you're going to have.
Francis, I'd like you to sort of look into the future and tell us where we're going with regards to research.
The main caveat here is that this might be quite speculative, but I think in the future, possibly in the next couple of years, we will be able to do neuroimaging scans of youth and children, and hopefully be able to find a biomarker for depression or anxiety. And so in many ways, that doesn't sound that interesting, just to be able to find another way to diagnose the disorder. But what I think why this will be so important in the future is we will be able to find hopefully some neuroimaging or some biological measure of the level of anxiety or level of network dysfunction. Then you can then tailor treatments to see which types of treatments will actually change this alteration in neural networks. I think the best way to describe this type of research is if you think of the brain as a hub of like an airport hub where you have maps of airplanes going to Chicago, for example, and if there's a thunderstorm there, each person probably has a different type of map where everyone, for example, if you are from United Airlines, you are significantly effective. If you are from Delta, you're probably not as affected. And to be able to tailor treatments and to be able to use neuroimaging as a proxy of seeing how well you're doing. Ultimately, I think what this will help is this sort of question we've been discussing is, when do you know your child or adolescent is over their anxiety disorder? And when is it safe to stop or curtail the medication or the type of psychotherapy? Because you can then use, hopefully in the future, the patient of the future will be getting a neuroimaging scan at the beginning of treatment and then get another scan in the middle of treatment and then a scan at the end of treatment, and to see whether or not how they've been progressing. So it is not something that will replace clinical interviews or clinical assessments, but will provide psychiatrists some way to proceed this way. And even though this sounds highly speculative, recently in this past year, there's been a paper published in Nature Medicine where a colleague of mine, Connor Liston, was able to find this actually for depression in adults. And we think that this is something that can also be transported into studying depression in youth as well as anxiety in youth, where he was actually able to do neuroimaging scans and actually find different subtypes of depression based on alterations in neural networks. And I think this will be sort of the game changer, hopefully, in the future, where we will have not just some type of way to diagnose, but inform treatments and to inform how the brain is actually being altered by these various things.
So just as if somebody has high blood pressure, they may have headaches, they may have other symptoms, but we actually check their blood pressure.
Exactly.
Monitor it, see how it responds to treatment. We'll be able to have, above and beyond the symptoms that the person experiences, really be able to look into the brain and see what's going on.
And just to be clear, it's not as if it's just a simple brain scan. There's a lot of sort of, at the back end, this high-end machine learning computer algorithms, because the brain's obviously very complicated. But the fact that we've been able to tap into and use a sort of supercomputers to essentially decipher this, I think is a great step forward.
Anne-Marie, what do you view as success when somebody's receiving treatment?
Well, let me say this. Anxiety is normal, we know, we all have it. If you have an anxiety disorder, you're likely going to at least have struggles at different points in your life when things are really challenging. What I see as success is, I think of right now the handful of young adults I'm treating who I had treated when they were children. And we had worked together. Some of them had medication and cognitive behavioral therapy, but I was doing the CBT. And they did well back then. They themselves called me. And I every time, and I just got another call today from someone. It's been 10 years since I've seen her. They're having struggles in the transition to adulthood in different ways. They come in on their own. We've been working together. It's able to be short term, and then they move on. Success to me is knowing where your vulnerability is, using skills to manage it, and knowing when to reach out and get help.
Well, I want to thank both of you for joining me today and for the work that you're doing, both clinically helping individual families, patients, and the research to improve our ability to do so moving forward. Thank you both.
Thanks for having us. Thank you.
Anxiety in young people is common and should not be overlooked. If you're concerned about your child at any age, from elementary school age to teenager to young adult, seek help. Do not allow your child to suffer in silence. Treatment works. Remember, with help, there is hope. Until next time, I'm Dr. Jeff Borenstein. Goodbye. Do not suffer in silence. With help, there is hope. Healthy Minds is brought to you in part by the American Psychiatric Association Foundation, the Graham Beck Foundation, and the New York State Office of Mental Health. If you would like to watch our expert interview in its entirety, log on to bbrfoundation.org/healthyminds.